giant of limitless power at man's command. And where was it science found that giant? In the atom, a particle so infinitely small that it takes over 100 billion atoms to make up the head of a pin.
This is Out of the Basement, a podcast dedicated to radiation medicine.
This is Dr. Jason Beckta beaming up from the Vermont mountain basements with the final wrap-up episode of the Xstrahl sponsored miniseries on low-dose radiotherapy for osteoarthritis. And apologies for the belated timeline where I have discovered that I am actually not superhuman and am subject to the limits of time, which is very frustrating. But we won't get into that here because I'm hoping this episode can be somewhat evergreen in terms of a compendium of everything that we've talked about leading up to this point, or as a quick reference for trying to convey to colleagues, either within radiation oncology, radiation medicine, or without, about what this is, why it works, why you should do it, why you should listen to those of us who do it, why you should recommend it to patients, so on and so forth. And I do think we can start with the history, which is very classic, very cliche, but as we all should hopefully be aware, our good friend Wilhelm Röntgen discovered what he called X-rays in 1895, and in 1898 they were using X-rays to treat arthritis. And as I'm very fond of pointing out these days, if you can find a medical treatment that is still in use today, that was first used before the invention of the airplane, tell me about it. Now, for some perspective on that, X-rays were being used for arthritis in the same century as the discovery of hand washing, which was 1846. And it was definitely before the airplane. But my point being, when you hear people decry the lack of compelling evidence or whatnot, I, at this point, just believe that they have never actually looked for the evidence, and they are just saying that simply because this was not taught in medical school or in whatever residency they went to. And ignorance of the evidence is not the same as lack of the evidence. And in the spirit of this podcast series being brought to you in part by Xstrahl, who are makers of very fine orthovoltage devices in use worldwide, including America, for osteoarthritis and many other diseases, the question of, well, they didn't invent linear accelerators until in the mid-1900s. How in the world were they treating anything, I guess, really, with X-rays back in the turn of the century of, the turn of the century is in the 1800s into the 1900s. And it was done using, in some cases, orthovoltage-based energies, where I actually haven't gone back and looked at this thoroughly. I'm sure we can find examples of things like cesium or radium or those sorts of things, the actual isotopes and radioactive elements. But so I think a common question that may come up, or I guess I should say a question I have personally been asked more than once and have seen asked more than once, but in the concept or in the question of using orthovoltage-based energies to treat arthritis. So number one here in America, first and foremost, the superficial devices you see in dermatology offices are not the only type of orthovoltage device. So those are usually the 100 kVp. Those are definitely inadequate for treating arthritis or treating anything below that. But just like all elephants are animals, but not all animals are elephants, all 100 kVp superficial devices are orthovoltage devices, but not all orthovoltage devices are 100 kVp superficial devices. Can we just get over that? I'm most familiar with, obviously, with what Xstrahl makes, and there is a 200 and 300 kVp versions of the machine, and they each have different requirements in terms of shielding and energy and whatnot, but 200 kVp is definitely doable for basically all but the largest body patients in like hips and things. So even with a BMI of 50 or 60, you can still treat that person's feet and hands and probably maybe even knees. you're going to really start to struggle with like shoulders and hip. That's something to keep in mind. But for most people, most patients, 200 kVp is going to be more than adequate. And it's mostly just remembering the depth dose curves from when we took physics boards. And so the prescriptions look a little bit different, and you're prescribing to midplane. So we're talking about, let's use a foot as an example, and you will want to do an APPA setup. And I'm assuming this is what they did back in the 1900s. I have yet to find any photographs. If anyone has any photographs of some sort of joint treatment or arthritis treatment or anything really of some sort of non-isotope based radiation treatment from 125 years ago, I'd love to see it. There's really cool pictures of Marie Curie actually built these mobile X-ray units for World War I. Like they were cars with X-rays in them that she personally drove on the battlefield. Those pictures exist. There's not a lot of them, but they are super cool and you should go look at them. But if anyone can find anything like that for things like arthritis, I'd be super interested. But so what I imagine, what you can do today, and what I imagine was done back then, imagining we're treating a foot, you do a regular APPA beam arrangement. And in this case, the AP would be the top of the foot, the dorsal aspect of the foot, and the PA would be the ventral aspect of the bottom of the foot. And you prescribe roughly 0.35 gray at a 2.5 centimeter depth using the 200 kVp energy. And that is per beam, meaning a total of 0.7 gray per day. And you might be saying, well, that's more than the 50 centigrade per day, the 0.5 gray. Well, how does that work? Well, again, depth dose curve. So at midplane, which is roughly, again, we're just using averages here, 3.5 centimeters. You have to measure this out. That same beam would be 0.32 gray. And at 4.5 centimeter or 1 centimeter past midplane, the dose would be 0.29 gray. And then on the other side of the foot, the exit dose would be 0.21 gray. And this is obviously easier to visualize, but this is just to illustrate that this is not superficial. You have, if you're starting, now in this example, we're just doing one beam, all right? That one beam coming into a foot with a 200 kVp energy, an orthovoltage energy that is above the superficial, but the 200 kVp energy, and it is delivering 0.35 gray. The exit dose on the other side of the foot is 0.21 gray, give or take. It is going all the way through the foot. So then when you were doing the APPA beam arrangement, you're adding those together, and one side of the foot is thicker than the other, but you are getting approximately 0.64-ish gray or 0.6 gray in the midplane of the foot. Now, obviously, if you were to do this with a real orthovoltage device in real life, you would have this. So you would this is why you would still simulate even with an orthovoltage device for arthritis, because you can precisely measure these depths for an individual patient, and you can do the actual physics for this because you should have a physicist who would help you with this. And these numbers would be a little bit off, but with most feet in most people with a 200 kVp orthovoltage device and an APPA beam arrangement, you can very easily get at depth the appropriate prescription. Now, obviously 0.6 is a little bit higher than the 0.5 that you would normally do, and you can tweak this to your heart's content. But just as an illustration for how back in the olden days, back when the Wright brothers were flying planes, and now back in 2024 or beyond, orthovoltage devices can effectively treat things like arthritis. And then you can also get into the physics of the Z difference and the greater bone absorption of orthovoltage energies. And the point being, I have discovered that in talking about these things, Xstrahl sponsorship or not, there seems to be a disturbing lack of understanding of physics for people who had to take physics boards. And I also learned, and this was on me, that my experience of getting to use one of the olden-timey orthovoltage devices during residency and having one of my attendings in particular gleefully ask me to hand calc keloid treatments on the orthovoltage device, that was probably not a normal thing, is what I have gathered from people. But we have the first use of X-rays for arthritis done in 1898. That was over in Europe, and then you have it first done here in America in 1906. And when you go into the literature and read the papers from the 1910s, the 19-teens, the 1920s, the 1930s, the 1940s, you get the picture. There are literally thousands and thousands of patients reported in the literature with positive results from low-dose radiotherapy for osteoarthritis. Literally thousands. And it's right now, by my calculations, by at least what I consider to be the bigger and more robust, reputable papers, we're talking about 5,000 at least patients that show a positive effect. And so this nonsense over lack of evidence, it just drives me up a wall. But what happened? Why did this go away? Now, obviously, as far as I know, I'm the only one really out here theorizing about the societal, cultural aspects of the disappearance and reemergence of low-dose radiotherapy for osteoarthritis. If there are other people with theories about this, please point me in the direction of their work, because obviously I like talking to myself in a dark room, but I would like, if there are other people talking to themselves in a dark room about what happened 100 years ago to radiation. My current theory is tied to usually where there is a legit amount of social psychology and whatever discipline you want to invoke here, work on this in the context of nuclear power and nuclear energy. And you can kind of extrapolate a lot of the findings and the thoughts and the trends in the nuclear power scare. That was a Freudian slip, I think, which is why I uploaded that full lecture of the nuclear scam from Galen Windsor, which I will extrapolate on after this. But in the 1900s, when you had the discovery and applications of X-rays and radium and whatnot, there was a lot of hype, just like you could look at the dot-com bubble or the AI. I don't think AI is a bubble, but the AI hype cycle, any new technology sort of hype cycle, there's always a crash. And in radiation's case, there was a lot of mitigating factors. So after the initial few decades of super hype, we had the World War II, the use of atomic weapons. We had the Cold War and the fear of nuclear war and fallout, and Chernobyl. And depending on how closely you follow Galen Windsor, the plus or minus 3 Mile Island, but the concept and culture of radiophobia. And that's when you get into the work of people like Ed Calabrese over at UMass and the tremendous flaws of the linear no threshold model and the ALARA, or as low as reasonably allowed. And I think I find that work very compelling, especially with a lot of the primary evidence produced in terms of personal letters from Edward Muller and all those things. And I think the oil and gas industry plays a pretty heavy hand in this world. And chiefly you can trace it back to Rockefeller and Standard Oil, but the interest in the oil and gas industry of not encouraging the use of things like nuclear power plants, I think it has a knock-on effect in our world where obviously there aren't a ton of doctors that are using radiotherapy as a treatment modality. It's radiology is obviously huge and medical imaging is obviously huge, but we're a very small specialty and nuclear medicine is very small. And I think we're kind of an unintended casualty of the fear and loathing around nuclear energy. And I think that's a real big part of why this went away. I absolutely, positively, unquestionably do not think it went away because it doesn't work. And again, anyone who is saying that there is a lack of evidence for this is admitting that they have not looked at the evidence for themselves. If you have and you disagree with the merits of said evidence, that's an entirely different thing. But usually this is just straight up ignorance. And so you have a clear movement against nuclear everything in terms of physics and energy and whatnot that we were an unintended casualty of and a lack of advocacy on our part. And even if you do have strong champions in radiation medicine, it's not like there's a ton of us to have a very loud voice, because part two of why I think this went away is that you cannot put this in a pill and patent it and make $100 billion off of it. So you absolutely better believe that if something like Johnson & Johnson could have put LDRT in a pill and patented it and sold it, this would be everywhere. But you can't. And as we have all been painfully learning about the way the public perceives cost of certain medical interventions on a relative scale, there are a lot of huge consequences for a perception of the cost of a certain medical modality, when in reality, all of radiation medicine is the most affordable, the most valuable in terms of a value sense intervention that we have, especially in cancer medicine, but it could also be the same in everything else medicine. And those are the two reasons I deeply believe that we had this disappear, is just a fear of radiation in general in America and the lack of ability to put it in a pill and sell it to everyone and their mom for the next 100 years. But why do I bring that up at all? Number one is to, again, convince my colleagues who think there's nothing to this that there are very observable, large-scale reasons why this went away, and it didn't go away because it didn't work. But number two, this is themes and concepts that I communicate with patients when I am setting up or building my own low-dose radiotherapy for osteoarthritis practice, because patients are going to ask the same things that our elder colleagues will, and they deserve an explanation if you're going to be proposing doing something to their body. So the number one thing about building your own practice with LDRT is do not go set up a meeting with your orthopedic surgeons at your hospital. It's not going to work. Well, it might work. I've heard it work once or twice. Orthopedic surgeons, if you're listening, I love you. You're great. But everyone else, don't go talk to them, because you're going to be perceived as a direct threat to the most lucrative thing in any hospital, in any practice, and that is joint replacement surgery. And again, I would never propose that LDRT will supplant joint replacement, meaning I do not think that it will cure all osteoarthritis permanently in everyone. I view this as a bridge, and I would be surprised, I would bet, that if every single radiation oncologist in America started doing this, and you saw 3, 4, 5 million Americans per year receiving LDRT for osteoarthritis, it would have a very small effect on the total number of joint replacements. The only way I would see it changing would be, one, I think you might have a chance to quote unquote cure. I don't even know if that's the right word. I think if you catch patients young enough, so like if we're talking about a 42-year-old person who went too hard in CrossFit one time and they haven't really eased up and their right knee is really killing them, and you do the radiation, then the LDRT, and then they start not going to CrossFit. They're more gentle on their body. I think those scenarios are where you could, I don't know, cure, is that even the word you would use here? I think that type of situation is where you could permanently, more or less, reduce or remove osteoarthritis pain. I do not think that a 75-year-old person with polyarthritis, every joint in their body hurts, and man, their right knee is killing them, and they're just real nervous about doing surgery, but that's their only option left. I think that person is going to get a right knee replacement no matter what. I think LDRT might buy them some time, and because the best medicine is no medicine, everything has a side effect. There's complications to everything. The risks involved with LDRT are incredibly small. Probably the car ride to and from the treatment is the riskiest thing. And the risks of joint replacement are much higher. Now, that's even if you have the best surgeon, the best anesthesiology team, the best everything, it's still surgery at the end of the day. And if you can delay the risk to that, then I think there's a net positive there on an intangible sort of mental health scale. But the orthopedic surgeon's not going to see it that way. Because the other thing you can also think of is that, and there's lots of studies on this in terms of the cost to society of osteoarthritis, in terms of cost of missed work from just too much pain or reduced productivity, or cost in terms of over-the-counter drugs like ibuprofen and Tylenol, and then the side effects of those. Because if you have somebody who's just slamming ibuprofen because they are in so much pain, then, they box their kidneys or they develop some sort of ulcer or whatnot. That's a cost that's due to the arthritis. And we could have a very big benefit on that. And that's how I think of it. That's how I would frame it, is that you are not curing everyone's arthritis. You are delaying time to surgery and or reducing the costs and the complications of the non-surgical interventions that lead up to a surgery, of the medication use and the decreased quality of life and decreased productivity, all of that. And the natural inclination, whenever anybody thinks about starting this in their own practice, is I'm going to go set up a meeting with my orthopods. Don't do that. So what I've done when I started this in my prior practice, when I started this here, when I came to Vermont, is I just talk to my own follow-ups, or, the follow-ups I inherited from the prior physicians. Because who's our patient population? It's a bunch of people in their 50s, 60s, 70s, 80s, 90s, 100s. It's an older population, and the prevalence of arthritis is huge in an older population, and especially in America. I would guess that 60, 70% of my patients in follow-up already had an existing osteoarthritis diagnosis in the chart. The other 30 to 40 probably should have one, but they've just never had it officially coded. It's hard to find a 75-year-old person who does not have one joint with arthritis pain. They exist, but it's uncommon. The reason I like doing it this way is, one, the biggest hurdle is the radiophobia, is the fear of radiation. And especially in the modern era where radiotherapy is a lot better tolerated due to toxicity and just everything's kind of better in general. If you have a 75-year-old woman that had a stage 1 breast cancer that you treated with, APBI, a 5-fraction breast regimen, chances are pretty good she had almost no side effects. Chances are pretty good that she was initially very nervous about the radiation. Then when she saw it and underwent it and recovered from it, or had zero side effects from it, she's no longer scared of it. And it is very easy to talk to somebody about something that they are already knowledgeable of and not terrified of, than if you try to just pitch this crazy thing, or this crazy sounding thing, to somebody who only knows radiation from, CNN or Godzilla movies. It's very different. And the way I started was to just bring it up, because usually I love open-ended questions. So I always will ask people if something else is bothering them or something else is going on or whatnot. And often there'll be some joking like, oh, if you could fix my knee, ha ha ha. Like, that's literally happened. Like, I have literally treated people because they made a joke about, well, if you could fix my knee, when I asked an open-ended question and a follow-up. It's that easy. And then I say, well, actually, and then you just talk to them like normal. And so you walk through. I also like it because it's a lot easier to compare and contrast. So if somebody, let's say somebody had regular hypofrac for breast, Canadian fractionation 15, 16. So I just play off of that. Well, it's only 6 instead of 15. It's every other day instead of every day. And then I walk through you repeat it. You do one course. I check in at 12 weeks and see how much, if any, of a response. And then we talk about if we do a second course, things like that. So it's a lot easier to play it off what somebody already did. So that's why I absolutely love talking about this to my own follow-up patients, because they're not scared of it. You can compare and contrast. And I would say, wow, I actually don't know how many times I've had people say yes versus no. There's definitely people who, they don't really ever say no. They are intrigued, but they want to think about it. And then it would just depend on, I've had the I want to think about it crowd. Sometimes they are never interested in it, but sometimes in the next, if it's somebody I'm following regularly, like a prostate guy who I follow every 6 months, yeah, they'll do it on they really will. It's not like, when I tell my spouse, oh, I'll think about it. And I mean, no, like sometimes it's like that, I'm sure, but there are plenty of people who want to think about it. And then the next time I see them, they actually do it. And then what happens is you get word of mouth, because again, this actually does work. And it takes about a year in my experience. Now, obviously I might be a little bit more bold in terms of how many follow-ups I talk to or whatnot, but really once you can treat maybe 3 to 6 patients, and because 3 to 6 patients, and then a year from when you're starting on that, because it's going to take you, a couple months to get those first 3 to 6 patients anyway. And then they have to get through that first 12 week, and then anyone else who needs that second treatment. A year, give or take, is about when those things all kind of fall into place. And then they tell their friends and families about it. And then you're off to the races. So right now what happens in my practice is literally it's just word of mouth. And, as I'm fond of talking about, I work in a rural area and everyone knows everyone. And it really took off too. It's really funny now because when I started treating the staff, So when the staff started seeing the patient's results, and then they wanted to do it, and then they had results, and then they tell the other people who work in the hospital, I literally just have staff members showing up in the lobby asking for an appointment with me. I have never advertised. I have briefly mentioned it to my orthopedic colleagues simply because when I joined my current practice, the head of the medical staff happened to be an orthopedic surgeon, and I was meeting with him anyway because I was new to the medical staff. But the people just show up, and honestly, I can't advertise. I would die. I do not have the infrastructure here to support how many people would be candidates. And I would venture a guess to say most of you don't have the capacity for that either, because we greatly underestimate the number of arthritis patients in this country. We're used to the cancer patients in that population, and cancer, even though it's all we do day in and day out, that's a small population in an absolute and a relative sense. There's not a huge, we're talking about 30, 40, 50 million people with arthritis in America. And as the demographics of the American society in terms of age transitions to a top-heavy situation, we're only going to get more of them. That's how I've started. That's how I recommend everyone else started. Maybe one of you will come up with a different way, a better way. I'd like to hear about it. A common thing I am encountering now is people are aware of the clinical efficacy data, and that's still not doing it for them because Thomas Kuhn was right, and science does not move forward incrementally. It's a paradigm shift. I get it. I get you feet draggers. I understand. But also patients and referrings are interested in the mechanism of action, the laboratory data, which again, people who are claiming lack of evidence just haven't actually looked. But what I did to help make these conversations easier or to convert the unconverted is make a 2-page PDF on the in vivo, in vitro mechanisms of action of low-dose radiotherapy. So it's going to be based off my 2 most recent favorite papers of the radiation biology persuasion. The first is the analgesic effect of low-dose radiotherapy in treating benign musculoskeletal painful disorders using different energies, a retrospective cohort study, and the other being low-dose radiotherapy of osteoarthritis from biological findings to clinical effects, challenges for future studies. So both are review articles, and both are from 2023. And it's somewhat repetitive in a sense because the end result is always the same in that LDRT leads to an anti-inflammatory phenotype, a microenvironment, if you will. And that's how I think of this, is that both non-steroidal anti-inflammatories or NSAIDs like ibuprofen and corticosteroids like prednisone are anti-inflammatory through different mechanisms. And you have steroids being upstream of the COX-1, COX-2 inhibition of things like ibuprofen. But in the end, it's anti-inflammatory. And I would think of LDRT, and this is how I describe it to folks, as just another tool in the toolbox to accomplish the same endpoint. And the difference being that it's not a singular sort of pathway. It's not a singular sort of enzyme inhibition or kinase modulation, or pick your poison. So I will hit the highlights on this handout that I will have a link to in the description. But for modulation of inflammatory processes, we have the reduction of pro-inflammatory cytokines, such as IL-1 beta and TNF alpha, which are key mediators of inflammatory response. We have the inhibition of leukocyte adhesion. So LDRT reduces the adhesion of leukocytes to endothelial cells, limiting the infiltration of the inflammatory cells into the tissues. Then for modulation of immune cell function in the macrophages, we have the reduction of the release of pro-inflammatory cytokines such as IL-1 beta and TNF alpha. And in T cells, LDRT reduces the proliferation and activity of the pro-inflammatory CD4 cells and tips the balance of the T cells towards an anti-inflammatory state. For effects on endothelial cells, we have the reduction of inducible nitric oxide synthase, or iNOS, and LDRT decreases the expression of iNOS in endothelial cells, which reduces the production of nitric oxide, and that also helps to minimize the interaction of endothelial cells and leukocytes. We also have the alteration of cytokine production. The production of cytokines is reduced by endothelial cells, enhancing the secretion of anti-inflammatory cytokines such as IL and TGF-beta, again, as always, leading to an anti-inflammatory state. There is the effects on the fibroblast, like synovicytes or the FLS. So LDRT reduces the aggressive tumor-like behavior of FLS, which is a key effector cell in joint inflammation, with LDRT decreasing proliferation and cytokine production. For the bone cells, we have my favorite, which is the effects on osteoblasts and osteoclasts. So LDRT enhances osteoblasts, which are responsible for bone formation. In this case, they increase mineralization, which helps maintain bone density and integrity. And for the osteoclast, LDRT reduces the number and activity of those osteoclasts, which helps preserve bone structure and prevents further degradation. For a systemic immunomodulatory effect, English is sometimes hard. We have a shift in immune cell population, so you get the favoring of the anti-inflammatory CD4 T cells over the pro-inflammatory CD8 T cells, which is supporting the overall immune regulation and reduction in inflammation. In radiobiological DNA damage and repair standpoint, you have the low level of DNA damage and repair, and we're invoking everyone's favorite hormesis, where just like if you go to the gym and you lift weights, the stress you put your muscles under stimulates growth. Well, the appropriately low levels of radiation can do the same thing in a metaphorical or analogous sense. But you also have the reactive oxygen species, ROS, and antioxidant factors. So LDRT influences the balance between ROS and antioxidant factors within the cells, and reducing ROS levels and increases in antioxidant response. And then finally, just in sum total, we have a time-dependent effect, which is that LDRT often shows a delayed therapeutic response with significant clinical improvements observed several months after treatment. And so the delay is due to the gradual modulation of immune and inflammatory processes. And, these are all important in terms of how you think about this, how you talk about this to patients or potential patients and colleagues and referring physician friends. But this is, again, going back to my favorite talking point, where if you claim that LDRT does not have sufficient evidence, I would sincerely question if you have even looked. But it is a very different complaint if you have read the preponderance of evidence, both clinical and laboratory, and you disagree with specific elements of it. But there's a lot to disagree with 125 years of clinical use. And I should go back and see when the first laboratory-based paper was. A long time ago, we'll put it like that. Along with the delayed therapeutic response, that leads me into, what are we even doing? And I have kind of alluded to it earlier, but my favorite regimen, and I think it's probably what everyone is using, or most everyone, but it is a total of 3 gray in 6 every other day fractions, 50 centigray or 0.5 gray per day, with an assessment at 12 weeks and the potential delivery of an identical second course. So also 3 gray in 6 every other day fractions. And so when considered like that, that is where the 80% statistic comes from, or that approximately 80% of patients with inflammatory conditions such as osteoarthritis will see some level of response. That 80% is all comers, meaning people who got 1 or 2 courses. And so a couple notes on that. I do think that the data and my own anecdotal personal experience supports a lower dose, meaning 0.5 gray is superior to 1 gray, and that's seen in the laboratory data as well. I think this is more conventional or empirical, or it's definitely anecdote for me, but the every other day is important. And I haven't seen people make as big of a deal about that as the 1 gray per day thing versus the 0.5 gray per day thing. But I do think that 0.5 gray and every other day is superior to 1 gray and consecutive days. And the evidence bears out, at least for the dosing. The 12-week thing is my preference. I have seen people do it earlier in my experience, so it's weird. Sometimes what I'll do because I am taking these patients a lot of the times from follow-ups from prior oncologic treatments. I will stagger things for whatever reason. Like right now, I have a couple of people who are getting adjuvant immunotherapy for lung cancer, stage 3 lung cancer. And because they are in the clinic anyway, so my practice has the chemotherapy infusion chairs right next to my linear accelerator, and my office is right next to the medical oncologist. So we're kind of in a all under one roof setup. They're here anyway. I will have the opportunity to check in and see and treat multiple joints and sequences that line up with why they would be there anyway. So in those sorts of cases, I have definitely seen differences in responses at 6 weeks versus 12 weeks. And there are people who prefer the 8 or the 10 weeks. And really, I think you would be hard pressed to really conclusively know how things are turning out at 6 weeks. And we can just debate thereafter, but just my personal practice. And this is where I'll get into more anecdote and my own personal preferences and thoughts and experiences. So number one is when to do the second course immediately versus keep it in your back pocket. I am a big fan of keeping it in my back pocket for just in case. So if I treat somebody, they come back in 12 weeks and they tell me that they've got 70% improvement, I really want to hold on to that second course. And sometimes people agree with me, sometimes they don't. And ultimately, I do what the patient wants to do. So I've definitely had people who have wanted to go for the gold. And it's usually the people who are getting that good of a response when they do the second one, they do get an even better, there is additional improvement. It's like I have not really encountered somebody who got zero benefit from the first course and then had a decent amount of benefit from the second course. There's always something. There's always a little bit of something. What I will get is people who think it doesn't work when, whoever's doing the intake or when the patient is asked sort of casual questions like, oh, it didn't work. What that usually means is the patient still has pain. And it's very important to ask these follow-up questions. And I think this might color people's experiences or some of the data where they will say, oh, well, how did the radiation go? They're like, it didn't work. And what they mean is that it didn't cure their arthritis. You'll see, I usually ask about the peak of the pain. So how bad is your worst pain now compared to how bad was your worst pain prior to treatment? Or do you find yourself having more hours in a day with reduced pain or no pain? Or do you find yourself being able to sleep better at night? Or do you find yourself with increased range of motion? Those questions, if you start asking those questions and then the light bulb will go off. And there are a lot of people who are like, oh yeah, I have noticed that the pain used to get up to an 8 out of 10 and now it gets up to a 4 out of 10. Or I will try to walk up the stairs and I used to have terrible pain by the time I got to the top, and now I guess I can get up and down the stairs without too much of an issue. So it's very important to ask more detailed questions about the nature of the pain and the use of, and there are other sort of conservative treatments where people will notice that they're using less over-the-counter medication or ice or, all that stuff. Because then really the question comes down to, would you ever do a third course? And there's not really data that I'm aware of. I know people do it. For me, I'm very mindful of that 10 gray line, and where there's no credible evidence that there's a secondary malignancy for radiotherapy below 10 gray, but there is above 10 gray. And so I feel like you're increasing the risks after, and not if you're doing 3 gray, if you would do a fourth one, you're still technically below it for 3. It's just, where's that line between cell killing, like how many repeat times over what time frame? And the short answer is nobody knows right now, and maybe someday, but we don't know. Fortunately, this hasn't really come up for me all that much yet, simply because for the people where this would be an issue, it would be the people who had great responses for the first 2. And in my experience, usually if they have a response, it's going to be at least 6 months. I haven't really seen people who had a good response from the first course who had a duration of less than 6 months. But 6 months is where I usually see the line. Because of these timelines, I just haven't been doing this for enough years to really get in the weeds about the third fraction. Maybe in another 10 years, I'll have a better answer for that. But the other anecdotal thing that I have seen that I'm not sure if it's in the literature or not is that the people who notice a change while they're on beam in the character of their pain and the nature of their pain, those tend to be, that's a positive predictive or prognostic factor. And it's almost like a pain flare is what it reminds me of. So I definitely do have people who will have fluctuating improvement in their pain. And that is something that happens. But more commonly, people will tell me that it's a pain flare essentially. And I find that to be a very positive predictive factor. It doesn't mean that I haven't seen people who have no changes, have nothing work, but I feel like the pain responses are more dramatic, are more significant when there's a change while on treatment. And I'm very careful to actually not say that to somebody until I see them in follow-up or at the end of treatment. I don't want to bias them in a certain direction or to get them disappointed if nothing happens. But the change in the nature and the character of the pain is something that I think is positive. In terms of contouring targets and treatment planning, I think the Spanish Atlas that we talked about earlier, and I'll link in the description, is very helpful as a starting point. And I think the number 1, 2, 3, 4, and 5 most important thing is big fields, big targets. I do think that it is important. And if you think about it in a conceptual, in a logical manner, where if LDRT is modulating the general immune environment or inflammatory environment through immune cells and cytokines and chemokines and adhesions and interactions, it's very important to get the entire joint capsule, to get the surrounding tissues, because the inflammation in a joint area has an avalanche effect, whereas a bystander effect. And adjacent tissues will begin to show inflammation. And if you are too cute with your fields, if you do postage stamp fields, you are not giving the radiation a chance to work. And I do think when I've talked to some of my friends who haven't had as successful of an early experience with this compared to myself or others, when I look at their field, they're very small. So remember, this is not oncologic doses. This is not 70 gray. You don't have to follow sarcoma rules of sparing a strip of skin. Big fields, big fields, big fields. I try to keep it as simple as possible. So I leave the setups as much as I can to the therapist in terms of comfortable for the patient, in terms of reproducible for the therapist. These days I like to use Vaclox a lot. It's very helpful. The old standby of APPA or opposed laterals works great. Beyond that, I think you're starting to get a little cute, but especially if somebody has a bigger body, that can be difficult to just do in an APPA. But you can follow the standard 95%, 107% cold spot, hot spot sort of thing. Don't overthink it. That's the other most important thing, I guess. 1 through 5 is big fields. 6 through 10 is do not overthink this. What is the consequence of having 115 hot spot? Well, one, I don't know what's going on where you would have one of that. It's a little ridiculous. But what's going to happen? 115 hot spot on a 3 gray dose? Come on, you're fine. Don't overthink it. The side effects, I have seen minimal to no. Honestly, it's no side effects directly from the radiation, and that makes sense given the 3 gray. What I tell patients is the 2 side effects are time, meaning that, they got to drive back and forth. It is a lot quicker comparatively to what we're used to for like 35 treatments for head and neck or whatnot, but there is a time side effect, and there isn't a discomfort side effect of the table itself. And this is what I tell the cancer patients as well, because we forget, if you are 85 with low mobility and a bunch of aching joints, climbing up onto that flat Linac table ain't too fun. And I'm sure those of us who treat breast with even hypofrac, 15 fractions, people's shoulders start to hurt. You wouldn't think it. 15 minutes, 15 treatments, I definitely will see it. And so that's usually what I warn people about, because it's uncommon. Again, I haven't really seen direct radiation, maybe some dry skin in someone's hands here in the New England winter. But I think the big one I write in my notes, especially early on, is that there's no evidence or no known complications for any future surgery, because surgeons, the joint replacement will probably happen anyway down the road. So I make sure to document that there's no evidence of secondary malignancy from 3 gray, or total 6 gray if it's the second one. There's no incidence of complications from surgery. Now, I'm not saying that it cannot happen. Anything can happen. I'm sure somewhere out there, somebody has gotten cancer from 2 gray. I'm sure somebody out there has had some surgical complication from 2 gray, from however you end up getting just 2 gray. Anything can happen, but there is no credible preponderance of evidence that either of those things would be late long-term side effects. And for everyone's favorite topic of billing, I don't know what else to say other than I have had this covered by insurance every single time I've done it in New York and Vermont. And all of my friends and colleagues who do it have most of the time have this reimbursed without any issue. There are, of course, the occasional, I always hear, and this happens for other things too, obviously, where just somebody will get feisty, some like Blue Cross Blue Shield of Minnesota, some Medicare Advantage subcontractor will just get some frisky denial battle that they want to do for no good reason. But you want to use for ICD-10 codes, you want to use the specific M codes, the M, they're all in the M codes, so they're not the C codes like cancer or D codes for DCIS or whatnot. They're M codes, and there's very precise. So like, left knee osteoarthritis or right knee osteoarthritis. So use those M codes. And the safest, most conservative way to have zero denials is to bill complex isodose or 2D without IGRT. And that has never failed me. And the reminder on that is that and bill it like a bone met, otherwise, like, if you're confused about that, well, how would your staff bill a 2D bone met with APPA? Just you bill it like that, except you just use an M code. The average cost in Medicare dollars of that, depending on which specific code you drop in quantity and whatnot, it's about $2,000 by Medicare, standard Medicare dollars. And compare that to my favorite was a New York Times article from 2013 where the total cost of I think it was a knee replacement or the hip replacement, but it was like $113,000. And you can go to like Blue Cross has an internal study that they were comparing across the country, all their different local carriers and whatnot. And the cost of just the surgery will range anywhere from $30,000 to $70,000. And that's not counting like the inpatient stay and all that. Pound for pound, it's really the most value-driven intervention possible, because what I will see is somebody who will come in and they will get significant pain relief after one course of treatment, and it puts off a joint surgery. It drastically improves their quality of life. It reduces their use of over-the-counter things like NSAIDs, and it has a significantly less price tag, significantly smaller price tag than a joint replacement, which for the orthopedic surgeons who might listen to this will happen anyway, eventually, probably. So this isn't a threat. It will delay things a bit. So it'll ease up your schedule. Like, it's a win-win-win-win-win for everyone, for patients and rad-oncs and orthopedic surgeons and society. And the only one who loses is Johnson & Johnson and AstraZeneca and Stryker, and who can't try to sell a $30,000 a month arthritis drug. But, 2D, aka complex isodose, it will usually also get reimbursed if you bill it 3D. And, there's a lot of local people really underestimate how much local variation there is, geographical variation in this billing. It is very regional. It really depends on your hospital or hospital system or practice, what insurance the patient has, and what contractor they're using, benefits manager, in what state you're in. Because a Medicare Advantage plan from Blue Cross Blue Shield in Vermont is very different than a MA Blue Cross Blue Shield plan in Tennessee. And it is hard to talk about these things in generalities, but the one thing I know for certain will get you denied every single time is if you try to do 3D IGRT. If you try to bill 3D with IGRT for osteoarthritis, it ain't going to work. You're going to have a bad time. Don't do it. Just save yourself the trouble. Do not do it. Ideally, complex isodose or 2D if you have any control over it, because I talk about this like we're not a bunch of W-2 employed physicians and the billing department's going to do whatever the billing department's going to do. Some people have more control over this than others, but putting that out there. And specifically for evidence, I would just really encourage people, if and when you encounter somebody holding up those stupid phase 3 trials that were negative, go pull out that last episode on that was focused solely on those 2 trials and why they're bad. And they were literally designed to fail. And I am very suspicious about why they were designed that way, but don't let people push you around with that. And same with being very cognizant of the word you use if you publish on these things in the future or talk about these things. Insurance companies will twist whatever they can to not pay. Insurance companies only get paid by withholding dollars for reimbursement. And if you write things in papers that say these treatments are experimental or more investigation are needed, I would consider that best practices, and that anyone, especially any doctor who claims we've got everything figured out, we've got all the evidence we need, is a quack, and you should not listen to that doctor. There's always more evidence that needs to be needed, but I can tell you with utmost certainty, 100%, that there are insurance companies out there that will fight things and deny them. And even if you are the author of a paper, they will try to tell people that, oh, well, this paper says it's experimental investigational. And then I will say, well, I wrote that paper. And that was just saying it because that's what a responsible scientific citizen would do. And that falls on deaf ears because insurance companies just hear the sound of cash registers in the background as they follow. So they don't count sheep. People who work at insurance companies count dollars withheld. So just be mindful citizens in terms of in future publications how we talk about these things, because while obviously all treatments need more investigation, low-dose radiotherapy for osteoarthritis has been in use for 125 years with more in vitro, in vivo, and clinical data than many, 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 many other treatments in medicine. And I'm very excited to see future evidence coming out, such as, well, it's not arthritis, it is LDRT, that the Alzheimer's stuff is very compelling. And there's some very interesting things coming out for LDRT and Alzheimer's. I don't think you can use an orthovoltage for whole brain, sadly, but, really go check out Xstrahl's website, their YouTube. They're lovely people. The orthovoltage devices are as easy to use as I say they are. If you don't believe me, go look at the YouTube videos. I have seriously considered, if I ever leave my current job, which I have no plans of doing, but I could just set up a farmhouse practice with an orthovoltage and just me, myself, and I just sit there treating joints all day. And that might be that might be my retirement plan. I might just wear flannel and go buy mittens from Bernie, and you'll see me in a bright red Vermont barn, my maple syrup sugaring shack on one side, and me personally just doing orthovoltage LDRT treatments to the elderly citizens of Vermont, or not so elderly, because at the end of the day, I will be doing this to myself the second it is necessary. I will literally be doing my own plan and putting myself on the machine the second I think it's pertinent. And then I'll finally get to know what it's like to be on the other end of Linac or an orthovoltage device. But I will continue to do these sorts of podcasts on LDRT, and apologize for being very slow to respond to emails or other things, as I've been buried under an avalanche of solo rural radonk work and other crazy tales that comes from when you live in the mountains. And I can tell you with utmost certainty, more utmost certainty, that even in just the past 2 or 3 years, it went from, I could name all of us who are doing this in America, or, most of us, very quickly. I have seen that there are innumerable practices adopting this, and the Astro Spring newsletter came out focused on this, and hopefully, if all pans out, the 2025 Astro Conference will focus on this and at least have a large component of this. And, if it didn't work, you would not see the rapid uptick in utilization that you're seeing right now. I think the main thing we all need to be prepared for potentially is an insurance battle, and to be on the offensive for that. We can't let what happened 10 years ago happen again, because dollar for dollar, the value that LDRT brings into the arthritis space for Americans is astronomical. And I could be totally wrong, and maybe the insurance companies will do the math themselves and they'll see that the $2,000 or, Medicare dollars compared to the $100,000, and I'm exaggerating a little bit, for joint replacements, and that math seems pretty easy, but I don't know. I'm just a doctor. I'm not a fancy math guy. But if you hear rumblings or when it happens, just fight back. This is a slam dunk in terms of benefit for everyone. And there should be no apologies or backpedaling. If you're skeptical about doing this, call me. Pretty much everyone knows my number. I'll probably respond faster than an email or some other way. But I think we should all be very excited to see this come back, especially patients or future patients like me. Maybe I'll let somebody else treat me. I don't know. What are the ethics around me treating myself with a linear accelerator? That's probably not kosher, right? All right. Maybe I'll let somebody else do my plan, but I'm clicking approve. All right. I'm going back into my basement. I'll talk to you guys later.
This has been a Photon Media production. Don't forget to like and subscribe on whatever platform you use to listen to us. Be well and beam on.